Muy buenos días. Vamos a dar inicio a esta sesión en 5 minutos en lo que se resuelve un problema de acceso al auditorio. Muchas gracias. Muy buenos días, bienvenidos a esta sesión de la Dirección de Investigación y hoy nos engalanamos con la visita del doctor Chiang, quien es un radiólogo intervencionista en UCLA y tiene una trayectoria académica muy interesante, ya que estudió la licenciatura en Johns Hopkins, hizo ingeniería biomédica y matemáticas. Posteriormente, con una beca Fulbright, estuvo un año en Alemania haciendo investigación en epilepsia. Luego se formó en la Universidad de Wisconsin como médico y como doctor en ciencias y también en ingeniería biomédica, y realizó su formación clínica en radiología diagnóstica e intervencionista en UCLA, institución en donde actualmente tiene el puesto como profesor en el Departamento de Radiología. Además de las responsabilidades clínicas, tiene un laboratorio de investigación translacional financiado por los NIH, centrado en la optimización de terapias oncológicas guiadas por imagen, con un enfoque particular en el cáncer de hígado, que es de lo que nos va a platicar hoy. Welcome, Dr. Chiang. It's a pleasure to have you here.
Thank you. Hello, thank you for having me, and thank you, Dr. Huerta, for being such a generous host. I work with Dr. Huerta at UCLA, and we have a lot of very interesting projects that I'm hoping to share some of that with you today, and also to tell you a little bit about some of the future projects we have planned. So let me just make sure this works here. All right, laser pointer works. So the topic of my talk today is about combining interventional radiology with immunotherapy. Talk about some of the things we do right now, and which is very little, and what we're going to be hopefully doing more in the future. And so I'll start by just telling you a little bit about the miracles of let me see if this works here. Can we go to the next slide here? Yeah, so I know we're at a pediatric hospital. Yeah, I don't know if this thing doesn't really fly. Oh, there it does. Okay. So we'll go back, show that video again. Can we play this video right here? This is a patient. I know we're at a pediatric hospital. It's going very quickly, but this is a patient, a 12-year-old male with metastatic osteosarcoma. Can you play this video again? So you go down, you can see there's bright in the bottom of the liver, and then in the right iliac wing, there's some bright there, some diseases. And so this patient was given nivolumab, which is a PD-1 inhibitor. I don't have to tell you about, this is quite basic, but usually this, the way it works is you have an antigen-presenting cell. The antigen is presented with the MHC to activate a T cell. There are some activating and inhibitory signals that must be activated, and so these checkpoint inhibitors block this inhibitory part of the signaling pathway, and you end up getting quite a good response. And so 2 months later, this very same patient, after 2 months of nivolumab, you can see no more disease in the liver and no more disease in the iliac crest. This is amazing. So that's the great thing about immunotherapy. What's the bad part about immunotherapy? This is a similar patient. This is an adult actually with metastatic melanoma, started on nivolumab, and during the middle of the treatment, you can see this is a CT scan of the chest. This is the ascending aorta, descending aorta. These are lymph nodes in the mediastinum, and you can see that they get quite prominent. And so the biggest question, and these are also FDG hot, so they were hot on PET. The biggest question is this progressive disease or is this inflammatory lymph nodes? You don't really know. And so this patient actually ended up getting biopsied. And just to give you, there's also this interseptal thickening in the lungs right here. Okay, this is also you don't know if this is metastatic melanoma progression or side effects of the nivolumab. So we actually ended up biopsying this, and this actually ended up being sarcoidosis. So this is an inflammatory response to the nivolumab. And so that's one of the potential downsides, is there's a lot of side effects to immunotherapy. And this is just one of them. People end up with colitis, myositis. There's a lot of different side effects that have to be managed. And so, so that's the one of the bad part. And this is the truth, is that melanoma, this is just an example. For single agent metastatic disease, there is this kind of plateauing effect. And so you can see the curve is very high in the beginning and it kind of flattens out and at the end. And so, with a single agent immunotherapy, a lot of patients, they do well initially, but there's a flattening of this curve, meaning that most of these patients actually they either have progression of disease or they pass away from the disease. And so that's the challenge we have, is that only a minority of the patients getting immunotherapy actually have a durable response. Okay, so that's whirlwind view of where we are at with immunotherapy. Now, what is interventional radiology? This is kind of what I do. My parents don't even know what I really do. So for diagnostic radiology, we diagnose diseases using X-ray, ultrasound, CT, and MRI. And in the United States, we spend 4 to 5 years learning about how to diagnose disease using these imaging modalities. Interventional radiology is similar in that we actually still use these imaging modalities, but we diagnose and treat diseases using needles and catheters. And so under ultrasound or CT guidance, or even MR, we can put a needle into whatever part of the body we'd like, or use catheters under X-ray guidance and select blood vessels. And it's nice because, if someone is bleeding, for example, and they're not good surgical candidates, we get called to stop the bleed. We can select those vessels and stop the bleed. Alternatively, if there's a clotted vessel, a vessel that is occluded, we can actually open it up again. So very commonly, we're known as like the plumbers of the hospital. So here's a case example. This is a kind of a busy slide, but I specialize in primary liver cancer, specifically hepatocellular carcinoma. And the only thing I want you to take away from this is that based on the level of liver function and the number of lesions, you can stratify patients based on whether they're very early stage, all the way to terminal stage. And in my specialty, whoops, that's going too fast. This is just a preview. And in my specialty, we are focused on very early to early stage liver cancer. So at this stage, the cancer is still considered curable. And even though the gold standard for these patients is a liver transplant, there's not a lot of livers to be transplanted. And so they ask us to often do ablation or catheter-directed therapy, which is something I'll tell you a little bit about. A lot of these patients also have underlying cirrhosis and compromised liver function, and so they're also, not good surgical candidates as well. So, so this is an MRI of an abdomen. Can we just pause it for a second here? Let me go back here. Here we go. Basically, it's cross-sectional imaging. We look at the enhancing patterns of the liver to identify where the actual lesions are, and we spend all of residency looking at, depending on the imaging characteristics on the arterial phase or the portal venous phase or the delayed phase, we can actually definitively diagnose a lot of these diseases. And so for a small tumor here, for example, this is on arterial phase. You can tell because the aorta is lighting up. You can see that this arterial phase, this lesion is lighting up on arterial phase beyond that of the liver, right? The liver is mostly has portal flow, and so when these primary liver cancers, hepatocellular carcinoma, are primarily have arterial flow, and so that's why they light up on this phase. And so this is an example of how we would do an ablation. And so we have a patient, it could be under moderate sedation or anesthesia, and using a combination of CT or ultrasound, we can actually we can visualize first on ultrasound the lesion, and we can guide a needle through the skin into the liver, into the tumor, and at the tip of the tumor, we can actually heat the tumor to cytotoxic temperatures well above 100 degrees. And this is nice because in this area where the tumor is at, you essentially get complete pathologic necrosis, right? There's no cells that are going to survive temperatures at such high temperatures. And people do really well, provided they don't have, metastatic disease or imaging occult disease. And so this is what it looks like immediately afterwards. You can see this dark area. We just cooked the tumor. And 6 months later, you can see that, where it was bright before, now it's no longer bright. So you have a good, complete pathologic response. And there's a lot of patients, actually, who do very well like this. This is essentially a curative response. And the follow-up is also very easy. They essentially get a Band-Aid because it's just essentially one tiny hole through a needle. And they get to walk home afterwards. So it's an outpatient kind of procedure. So this is another particular case. All right, so in this case, this is a lesion that they've seen in August, and this is the one, in October, right? You can see this lesion. You can see it's growing. And by the time this patient saw me in clinic, it's growing quite big. And you can look on ultrasound, right? It's grown, this is over 3 centimeters at this point. And in this case, it may be too big to do an ablation because you may not be able to put enough needles in here. And in this particular case, we can actually do this kind of combination TACE ablation. And so what we can actually do is we can go inside the blood vessel, and I'll show you a case of that. And we can actually put embolic beads in there, and that will not only kill the tumor, but it will also slow down the blood flow to the area. So you can see here, when we do these kinds of ablations, one thing you're always fighting against is the perfusion of the liver. So if you have very high perfusion of the liver, it's taking heat away from the ablation zone. Your ablation zone ends up being smaller, and you may not be able to cover the amount of tumor that you're supposed to. But if you do this embolization procedure beforehand, you can also not only stop blood flow to the tumor, but you can also use an ablation afterwards and create a larger ablation zone. So these are just a couple of, again, the arterial enhancing lesion. You can actually put a catheter in here and put embolic beads, and sometimes we can even put chemotherapy in here to treat just the tumor. Then we do the ablation, and actually we have a very good ablation zone with very good margins. So watch the time here. Okay, so this is an example. This is an angiogram here, right? We have a catheter going into the femoral artery, up the aorta, into the celiac artery, and you can actually see that we can actually find the lesions that are lighting up, right? And so with a combination of catheters and wires, I can actually put my catheter up into this area that has that's hypervascular. That's the tumor, and we can actually deliver embolic material into the tumor. So that's kind of what it looks like afterwards. Go to the next slide here. And so we play the screen on the left here. Yeah, so you can see here, that's what it looks like after. You can see that little black area. If you play that a couple times, just one more time if you can. Yeah, you can see here, see how there's little black areas? That's like areas of ischemia. So it's very localized disease. And look on the video on the right, you can see then I put in my ablation needles in there. And afterwards, we do the ablation, which takes maybe 20 minutes. We do the ablation right over there. And let's keep going. Next slide here. There we go. Well, here it is. I think you saw that already. So that patient did very well. So you have very good ablation zones, very local control. Again, just like with all ablations, these patients end up going home the same day. One other thing we could do, so I talked about with these catheters, we can put embolic beads to slow down the blood flow or stop the blood supply to the tumor itself. Or we could put chemotherapy. It's often paired with chemotherapy. We also do something called Y90 radioembolization. And in that particular case, that's for areas that are very difficult to reach with ablation. And so this is a patient with a lesion that's in the caudate lobe. And so, putting a needle through here, you're crossing through bile ducts, you're crossing through the fissure, ligamentum venosum, and so there's critical areas that may be difficult to go with a needle. And in those cases, we do something here called a cone beam CT, where we can actually map out all the blood vessels going to the tumor, Radioembolization, we use these glass beads. They're very small, 20 to 40 microns usually. And they get carried down the blood vessels, and they're pretty radioactive, actually, and I'll tell you a little bit about it. They're beta emitters. They penetrate 2.5 millimeters, so they're actually quite safe. They don't really, the patient's not radioactive. They're only radioactive 2 millimeters from the tumor. So, and the half-life is 64 hours, and so within 11 days, essentially decayed to background. And so you can put, because we're so selective, we can use very high doses of radiation. We can put 1,000 grays in there if we wanted to, actually, which is, our nuclear medicine colleagues are always, they always give us a call and be like, are you sure about this? But, it's very important that you're very careful with where you put these beads. But you can do it. So here's a particular case, again, catheter going to celiac artery. You can see the proper hepatic, the left and right hepatic. And in this particular case, the tumor is actually coming off, this is the caudate lobe, it's coming off, this is the middle hepatic artery right here, okay? And so I put my catheter up there, and you want to play this video on the right here, and you can see this is the tumor right here, okay? So we can actually move our catheter up to here and drop the radioactive beads, and they all go to the tumor, okay? And this is kind of what it looks like afterwards on the post Y90 scan. So very localized. And by the way, these patients are actually talking the whole time. Like they get moderate sedation or under local anesthesia. And after we get the initial puncture, they pretty much don't feel anything. And so usually that's the time when we just talk about our lives, our kids, and everything. So, and so these technical, so it's very safe if you know where you're putting these beads, and well tolerated. And so over the course of the next 3 to 6 months, you'll get what we hope is complete pathologic necrosis of the caudate lobe where the lesion is. So this is an example like local disease. Okay? And so so I talked a little bit about about immunotherapy, and I talked a little bit more about the interventional radiology, about some of the tools that we have at our disposal. And so this is how I would envision about what we could offer with, combining our skill set with those in immunotherapy, and hopefully reach out to our oncology colleagues. And so one thing is, because we're experts in image guidance, we can do image-guided drug delivery, right? So we are able to put needles and catheters exactly where the tumors are. And we're not going to put, if someone has diffusely metastatic disease, multifocal disease, we're not going everywhere. We're talking about oligometastatic, things where, you have limited number of disease burden, and we can potentially reduce the tumor burden with these image-guided techniques. The other thing we could potentially offer is image-guided biomarker discovery. Part of it is, we are able to get biopsies beforehand. And, as the people getting the biopsies, I think, we have a lot of techniques to actually analyze the data as well. And I'll give you a couple examples of that. And the last thing that and this is something that I've collaborated with Dr. Huerta about, is immune priming. Because, not only are we allowed to drop beads and deliver different temperatures, cytotoxic temperatures or cryoablation into the solid tumors, but when we do that, we actually cause a lot of local changes to the tumor microenvironment, right? And so, I think we always talk about, tumor microenvironment, the drug's not penetrating because of the tumor microenvironment. Well, now we actually have a chance to directly modulate the tumor microenvironment. And so I think this is a really nice opportunity for us to potentially collaborate in the future. So I'll just start with image-guided drug delivery. And so this is just a picture of a lymph node in the neck. This is a head and neck cancer patient. And one of the trials that we are doing right now is delivering oncolytic viruses into these lymph nodes for these metastatic disease patients. And so this is in collaboration with Replimune, one of the leading manufacturers of oncolytic viruses. And so if you go to the next slide, I don't know if you can play it, but yeah, you can see a necrotic lymph node. And so the idea is that, because we can directly inject, in this particular caption it says CAR T, but it could be any kind of immunotherapy or targeted therapy. Because we could directly deliver it into the tumor as opposed to intravenously and get it everywhere, right? I mean, if they have tumor just in the lung, like why would you do systemic treatment, into the legs or the brain. And that's going to be a real issue because you can actually, through local delivery, get improved local distribution. And because you have improved local distribution, you have less systemic toxicity. And as I mentioned before, you can overcome the tumor interstitial fluid pressure. High interstitial tumor pressure is often cited as a reason why a lot of the drugs cannot enter solid tumors, right? And so this is a way to potentially overcome that. Let me play this one. So this is one of the injections. The needle is, the oncolytic viruses, right? We can actually put the needle right into the target lymph node of interest and deliver the oncolytic viruses. And these patients do very well, right? It's not a systemic administration of a potentially toxic drug. It's very locally delivered. And so, I think one very easy thing we could do is to improve the potency of these drugs and reduce side effects, right? And so a lot of immunotherapy drugs, they have 40 to 60% adverse event rates like this, potentially could be improved through local delivery. This has been evaluated with other groups as well, right? So this is a group, this is another company actually, but what they try to do is catheter-directed delivery of CAR Ts for colorectal mets. There were two groups here where they infused CAR T with and without IL-2, and you can see here, and this is the original burden, and you can see, you can see increased, this is the CAR, the CD3 and the CAR construct. You can see there's increased accumulation inside the liver of the CAR T, so better local delivery of the CAR T into the liver. And even though this is a very preliminary study, you can also appreciate that this is the disease burden before, this is disease burden afterwards, and you can see the hypervascular rim from the increased inflammation after the CAR T therapy. And so, this is a potential very safe way to deliver cell-based immunotherapies. One thing that we're interested in, this is something that we work with Dr. Huerta on, is NK cells. And so we're particularly interested in NK cells because they're very safe. They have a very safe profile. They don't require antigen sensitization. They work in an MHC independent manner. And so there's a significantly decreased risk of this graft versus host disease or cytokine release syndrome. And importantly for us is that because they leverage they specifically target cells that look very different from normal native human cells, and so they specifically target cancer stem cells. And so that's coincidentally, we did a study showing that, these cancer stem cells, at least in liver cancer, are quite resistant. They can be resistant to local regional therapies such as thermal ablation. I'm not saying that these stem cells survive the 100-degree temperature after ablation, but we're interested in the peripheries where it's maybe not cytotoxic. You have imaging occult disease. And so, we hypothesized that this is a study that came out earlier this year showing that, you have a significantly decreased progression-free survival with these poorly differentiated low MHC-1 HCCs after thermal ablation. And so a lot of these patients get recurrences and they require additional treatment or they move on to systemic therapy. And so a lot of the challenges that I'll be talking about is, there's right now in most of the clinical trials, NK cells are administered systemically. There's also an issue with persistence of the NK cells within the host tumor, persistence and activation. And there's also an issue with ex vivo expansion, right? They don't expand very well once they hit in vivo inside the body. And so those are things that we could potentially address using our techniques in interventional radiology. This is more just talking about the stem profiles. So this is a poorly differentiated HCC. This is a well-differentiated HCC. These are the ones that, as I mentioned before here, these are the ones that don't do as well after thermal ablation. They have rapidly progress afterwards. And so, we have done some profiling here. Just showing you, this is the poorly differentiated HCC, this is the well-differentiated HCC. You see, comparing the MHC-1, there's significantly decreased levels of MHC-1, which is a critical marker for T-cell recognition. There's increased expression of CD44, a stem cell marker that we have, and decreased expression of CD54. So these are potential surface marker differences in these more aggressive HCCs. And so what we hypothesized is, well, why don't we put these NK cells, these are supercharged NK cells from one of our collaborators, and you can see here, they just eat them up immediately, which is amazing, right? I mean, you can just see it in real time. These are the most aggressive HCCs out there that current treatment modalities are not addressing very well. So, so the NK cells seem to potentially be a solution, provided you can actually get it to the tumor itself. Okay, next slide. All right, so one thing that potentially a unique resource we have at UCLA is that if you want to practice doing catheter and needle-guided procedures, it's very hard to do that in mice or rats. It's very hard to put a catheter inside a mouse aorta and celiac artery. You end up just dissecting the aorta, and the mice, they don't do very well. And so what we do when we test out our procedures with needles or catheters, we use pigs. We use pigs. And so we actually, thankfully, our leadership has really believed in using pigs as cancer models. And so this is the pig. This is a pig, and this is a human right here. So the pig has a aorta, it has a celiac artery, a superior mesenteric artery, gastroduodenal artery, the right and left hepatic artery. So the catheters, the anatomy is very similar. There's little differences, but you can use clinically relevant catheters and needles. And so this is our setup here. This is a dedicated Zigo. It's a robotic C-arm specifically to do angiographic evaluation of pigs. All right, so that's the model that we work with. And we have something called an oncopig. This is a transgenic pig with a P53 and KRAS mutation. And you can overexpress these mutations with a Cre-Lox construct. And so basically you can take some of the liver, so the P53 KRAS mutations is in every single cell in this oncopig. And by injecting the adeno, it's an AdCre, it's a Cre recombinase inside an adenovirus. By putting inside the pig, you can actually grow these tumors inside any part of the pig. And so that's what we have done. And so this is just a proof of concept study where we grew a liver tumor right here inside the pig. It looks quite similar to a human actually, on CT. But yeah, this is the pig tumor. And we can actually identify this tumor on imaging. There's a hypervascular rim. And we could actually inject the pig NK cells in here. And so you can see here, one of the examples, we can see the tumor after 1 week after injecting the NK cells. And then every week it gets a little bit smaller, okay? And by the way, this is an allogeneic NK cell delivery, meaning that the NK cells came from another pig, and then we put it inside this host pig. And no immune responses, tolerated very well, no changes in hemodynamics. And so I think, this really brings up very interesting possibilities compared to CAR-T, which you do need to do lymphodepletion beforehand, of which has a lot of potential cytotoxicity. We did not have to do lymphodepletion here. This is straight allo injection of NK cells through a catheter. So yeah, now I'm going to talk about biomarker discovery. Again, one thing that I'm sure everyone is aware right now, our current role as interventional radiologists is to biopsy these tumors. But there's a lot of subtle nuances to doing biopsies. I think because a lot of these tumors, they can have necrotic areas, there's a lot of tumor heterogeneity. And so you have to always make sure you're actually biopsying the correct area. And right now, that's something that we're looking into, is using potentially contrast ultrasound or contrast CT to identify the best places in the tumor to actually biopsy. Because, right, usually we get the order of, hey, just biopsy it and tell me what you get. But really what we have to do is look at where we get the most yield, usually around the peripheries. Another thing we can do is actually do venous sampling of the tumor and identify, what are the post-treatment responses to these kinds of systemic, CAR-T or NK cell therapy. We do adrenal vein sampling already right now for patients with, for example, hyperaldosteronism or Conn's disease or any kind of adrenal insufficiency. We already do that. So the principle is the same. You can do the same thing to take venous blood from the tumor. And so, one thing that we would like to do is actually help with the needle biopsy is find out who are the patients that are most likely going to respond to this kind of immunotherapy. That's something that, I think, a very easy thing that we could immediately doing right now actually is use better targeted biopsies to improve our patient selection for our different trials. So just an example, like these are the needle biopsies that we get. We have a banking program at UCLA where we flash freeze them as opposed to putting them in formalin, paraffin embedded. You can talk about like the different signals you're trying to capture using whatever preservation technique, but we found that the frozen actually do a little bit better for doing bulk RNA-seq studies, for example. Just a very easy study, like just on imaging, right? And so for liver cancer is interesting because it's an imaging-based diagnosis, not a biopsy-based diagnosis. And so our transplant surgeon and oncologist, they will treat based on imaging diagnosis without even getting tissue. So, this is just an example I have for them saying like, yeah, these are all imaging confirmed liver cancer, but you can see there's quite a lot of heterogeneity actually, even when the imaging looks the same. And so this is me trying to convince them that we should be biopsying all of these patients beforehand. And so there's a lot of potential multi-omic analysis you can do. You can do proteomics, you could do bulk sequencing. It really comes down to basically how you preserve the tissue though. And so this is a whole research topic on its own. When you flash freeze, for example, how is the quality of your RNA? Similar with proteomics, like how many proteins can you actually get if you do, FFPE embedding? So one particular interesting question we're interested in is, again, why are there recurrences after standard of care thermal ablations? I told you already, right, that the center is 100 degrees. Like, why do we have recurrences? Here's a real life example, all right? So this is a tumor right here, this dark part. This bright part is actually where I had ablated, all right? So we have good margins. You can look at this and say, okay, you treated everything you saw here. But 3 months later, look at this. This is an enhancing lesion. This is my treatment zone. This is a new lesion that grew on the peripheries. And so what I suspect is happening is that there's maybe little microscopic disease around here that you're not really capturing, that's being exposed to these hyperthermic temperatures. And so this is something you have to just be aware of when you do these thermal ablations. On the y-axis is the temperature. On the x-axis is the spatial distance from the center of the ablation zone, right? So in the center, you have the highest temperature, but as you move from radially, from this way or this way, you can see the temperature drops off dramatically. And so you can see that everything below this dotted line, maybe like 1.3 centimeters beyond the center of the ablation zone, you get this sublethal hyperthermic area. And that's the part we have a big focus on the lab on, is what happens when you heat tumor tissue to just these temperatures. Like, we know everything's going to die up here, but what about down here, right? And so that's a very interesting question on our end that we're actively studying. So for biomarker discovery, what we actually did is my colleagues actually, before my time, they actually had been biopsying a lot of these liver cancers, but they haven't done anything with these samples. And so I looked at some of these studies. I looked at patients who progressed after thermal ablation, which is this red dot, versus patients who had a durable response, which is this black dot. And we looked at, we already know the responders. Now we have their tissue samples from before they got the ablation. And so we're like, well, what are the differences between the two? And so these are FFP, these are paraffin embedded samples. And actually what we found was here, this is the blue, these are the responders, these are the non-responders. That on mass spec, you could actually get a good number of proteins, over, around 1,600, 1,650 proteins from each sample. And these are needle biopsy samples, not surgical resection samples, right? And so we got pretty good data from it. So this is something that I think any of us could do, right? We all have biopsy samples in our pathology lab. We could do mass spec on these to get proteomic samples. And we did, so we looked at these proteins, generated heat maps, looked at differences in size, AFP level, which is a marker for primary liver cancer, and responders versus non-responders. And what we found was that there was an upregulation of this protein called galectin-1. This is on a log scale, so it doesn't look that different, but there was a significant upregulation of this marker called galectin-1. And this is an interesting mediator for aerobic glycolysis, which is associated with cancer. And galectin-1 is also heavily involved in the immune cell, modulating the immune microenvironment. And so that's potentially a way we could get an insight whether someone would potentially be a responder to future immunotherapies. And this marker has also been implicated in many other kind of cancers as well. So we're not going out on a limb here saying that this potentially could be a role in ablation therapy. And so we did some validation with IHC and looked at, again, non-responders had a much higher expression of this galectin-1 marker. And this is a paper that was just published in Hepatology, but we did this study where we found a blocker of galectin-1. This is called OTX, and we gave this OTX sample to mice carrying an orthotopic HCC. We gave it for about a couple of weeks, and then we did the ablation, right? And so this is the sham tumor. This is ablation alone. This is sham ablation, so just the needle going inside with no heat. And this is the OTX plus ablation, so significantly decreased, a better local control of the liver tumor when you can block this galectin-1. And so just, again, all of this came from getting biopsy samples. And again, this is something that every hospital has, and I think something that you could potentially leverage for your own studies, for whatever disease process you're interested in. So last thing I want to talk about is immunotherapy priming. And so again, I talked about we have to prime the tumor microenvironment, especially right now with CAR T. You have to do lymphodepletion with fludarabine, and that can be nephrotoxic. Keep going here. And so we play a big role in actually changing the tumor microenvironment. So one thing is that we can stimulate an inflammatory cytokine response by delivering heat or ice or electrical energy into the tumor of interest. And we can also potentially release tumor antigens, right? And that's a very hot topic in our field right now, is like, well, we're the only ones that can actually deliver energy and like spread the tumor antigen everywhere. If they're going to be on immunotherapy and they need more antigen sensitization, this may be a potential way to do it. So there's always a big topic. Can we turn cold tumors, tumors that are not very interactive with the local immune system, and can we turn them into hot tumors, such as melanoma or like renal cell carcinoma? The melanoma is a great example because you can tell that it's hot. It responds very well to checkpoint inhibitors for a certain subpopulation of patients. We're trying to do that with other kinds of immune cold tumors like pancreatic cancer or maybe your liver cancer here. And so this is just an ablation, just showing people how you can actually turn, potentially, we're delivering a lot of energy into the tumor itself. And so one interesting example here, this is a renal cell carcinoma, right? It's about 6 by 8 centimeters. This patient was not eligible for surgical resection because the tumor was just so big. It was too big. And he actually had metastatic disease to the bones. And you can see here that along the sacrum and the iliac crest, right? And so he had this lesion here. And he actually underwent cryoablation. So we put a needle in there, and this is for palliative purposes, actually. At this point, they're like, not surgical candidate. Let's just make sure he feels good. Palliative purposes, you put a cryo probe in there, deliver a probe, and what happened? That original target lesion ended up shrinking, like 5.6 by 4.8 centimeters now. It got significantly smaller, and now he was actually able to undergo surgical resection. So he had a very good outcome, and so this is an example of what we call the abscopal effect. So you treat something away from the target tumor, potentially expose more antigen, a tumor antigen to the immune system, and get an off-target response that's favorable that may downstage a patient to better treatment, such as surgery or more local therapy. So that's the example of what I mean by immune priming. And so, I've showed you this graph before already. So again, poorly differentiated liver cancer, not there's a high rate of recurrence after thermal ablation. Can we combine that with NK cell therapy? So can we use the ablation not only as a treatment modality, but as a way to sensitize the immune system? And so this is a study, and this is with Dr. Huerta, a lot of this work was done here actually, believe it or not. So we actually did a mouse study where we had orthotopic implantation of a mouse liver cancer, and we did an ablation, a partial ablation, so we left some of the tumor viable, and then we gave NK cell therapy afterwards. All right, so these are our different experimental groups, right? We have the control group, then we have the liver cancer alone, the liver cancer plus ablation, the liver cancer plus NK cell therapy, and then the combination of the two. Okay, so, and what we found was that when you actually heat the tumors, you can actually cause the MHC1 surface expression to decrease actually, and that may be bad for like T cell therapy, right? But it's very good for NK cell therapy. Right, so you lose your MHC1, you increase the sensitization, the chances of being targeted with an NK cell therapy. And so you can actually see here, the red is our combination therapy. The tumor, this is the Gaussian luciferase, our marker for tumor burden. There was significantly improved, decreased tumor burden with the combination of ablation, partial ablation plus NK cell therapy. And as evidenced by, the question as well, is there really improved NK cell activity where you previously heated the tumor? And the answer is yes. Yeah, there's increased granzyme B activity, right? It's one of the mechanisms of NK cell therapy. In this combination group, there was, compared to just NK cell alone, there's significantly more granzyme B expression. And there's more IFN gamma release as well. And so all this to say is like when you heat tumors, you could potentially improve the chances that their NK cell function will work better as well. So future work that we are doing, that we're interested in doing, is we're looking at this kind of non-invasive way to actually heat tissue. So with thermal ablation, you're sticking the needle into the tumor, but you can only really heat for maybe 10 or 15 minutes. So what about, is there a way we can actually heat for like 1 hour or like 4 hours at a time? Now, I'm not saying we're going to heat it to 100 degrees for 4 hours. That would be bad. But can we heat it to maybe 45 or 50 degrees, 43 or 45 degrees, like hyperthermic temperatures, not lethal, to induce this kind of MHC1 shedding? And so we have this model right now where we have these little implants. These are tiny implants that'll fit through an 18-gauge needle, right? Same needle that you do for your biopsy. You can actually put these in here and put these inside of mice. And these implants are very special in that they can, they're engineered to cap the temperature. So it's a small, it's a way to, if you can set it to like 43 degrees, 45 degrees, 49 degrees, and it will only heat to that temperature. And then you heat it with this coil that's outside. So it's completely non-invasive heating. You have to do the implantation. That part is a little bit invasive, but you let the mouse heal and you can heat externally. And so the idea is that you can actually sensitize a lot of these tumor cells to future immunotherapy, right? And so by doing these kinds of heating, now you have, say, like, well, let's say you want to heat for 1 hour every day for a week. These kind of interesting possibilities come up of the best way to actually synergize heating with immunotherapy. And this is kind of a setup that we have going on right now. The interesting thing about this is the coil and has to be oriented perpendicular to these implants. And so we have this cage that's just filled with coils. So every time the mouse moves, it'll be perpendicular to one of these coils, and they'll actually be able to heat continuously for a long period of time, right? So if you only had one coil, you might only heat. The mouse would have to be under anesthesia for a long time. So this allows you to heat for 3 or 4 hours at a time, and to like 45 degrees, for example. Okay, so just to finish up here, overall, I think there's a lot of, I think we're just scratching the surface for combining immunotherapy with interventional radiology. Again, we use image-guided delivery. We can use image guidance to guide a needle or catheter into the tumor target. And so I think a lot of immunotherapy right now is just administered systemically. And there's a lot of side effects. And I think, that's the one thing that we can do very quickly with our expertise. This will minimize the toxicity, overcome the inhibitory tumor microenvironment for high interstitial pressures, for example. Image-guided tumor priming, I think, is going to be a very hot topic. So we can do local activation of cell-based immunotherapy, local sensitization of the tumor cells. We can increase the quantity and quality of immune cells. Instead of systemic lymphodepletion, for example, maybe we could just do lymphodepletion of just the area that we're interested in through catheters and needles. And we're also just scratching the surface for biomarker discovery and surveillance. A lot of work needs to be done about how to optimize these needle biopsy samples. But, I think we are starting to do serial biopsies for patients on immunotherapy to look at the changes in the tumor microenvironment after the immunotherapy. And so that allows you to you can pivot very quickly if you have that kind of information. To study that, this is all on the clinical level. On the more basic science level, to do catheter needle-based delivery, you do need a large animal model. You could use like a rabbit or a sheep. In our institution, we use a pig. I think having a pig tumor model is a nice thing to have if you want to validate these kind of procedures. You do need, this is another project that I work on with Dr. Huerta. If you have a pig model, you need to have pig antibodies, and you need to have a pig for IHC or for flow cytometry, so you kind of need to build up that platform as well. But when you have it, I think it's a very powerful tool, and I think it can help translation a lot, right? I think the FDA looks very favorably on these kind of large animal models, and that way you're not just going straight from a mouse to a human. So this potentially could be a way to increase the translational success rate of a lot of different immunotherapies. And but for like these heat-based priming for immunotherapy, you still need mouse models, as I kind of shown. So so with that, I'd like to thank everyone for your time and listening to me. This is my lab. They're all they work very hard, and special thanks to Sarah and for facilitating. A lot of this work actually came in collaboration with Sarah, and so I'm hoping we can continue this collaboration. I just saw her lab. It's very very good equipment, and I'm sure at UCLA, we have a lot of good equipment, but there's always a line to use things. I feel like we could potentially do things faster here. And also a special acknowledgement to Dr. Jewett. She's the one who introduced me to the NK cell work. Unfortunately, she passed a few weeks ago, and I'm really hoping we can continue her, in honor of her memory, to continue her work and continue the momentum we have going. A lot of excitement in our in the radiology community and the immunotherapy community on this kind of NK cell work, and synergizing with thermal ablations. And so with that, I'm happy to, this is my lab website, I think. But yeah, happy to take any questions.
¿Alguno de ustedes tiene preguntas para el Dr. Chang? Sí.
Hi, doctor. Nice to meet you. Doctor, I have a question. Do you have some control to avoid some liver inflammation? Sorry, because with the ablation, you call a lot of immune cells to do some scar and thing. Mm-hmm. And with the combination with the NK cells, you do a lot of inflammation in the liver. Mm-hmm. And do you have a control to avoid that?
Yeah, so I think part of it is the inflammation part, right? There's pro-tumorigenic inflammation, anti-tumorigenic inflammation. So that's a big debate. Is like maybe there's some people who say we want more inflammation actually, because that will probably improve the performance of the NK cells. Right now. So that's the part we're not sure of, and so to answer your question, we don't have a control, but we don't actually know if it's something we want at this point.
Thank you.
Another question? Puede ser en español y puedo traducirla si quieren.
Hi, Dr. Chang. Thank you for the ponements. I was wondering, you showed us a graph that demonstrated that usually patients who are resistant to ablation through heat therapy or through hyperthermia usually overexpress this marker galectin-1, and when you do this combined intervention of thermoablation plus the inhibitor, outcomes are more favorable. And I was just wondering, moreover or further from that marker of galectin-1, has your group studied the correlation between this differentiation stage or this differentiation subtype and the correlation with response to thermoablation alone?
Yeah, that was actually the main topic about just looking at histopathologic differentiation, looking at trabecular pattern, the nuclear atypia, for example. So we did notice, and this is also shown in many other interventions, that the poorly differentiated HCCs actually don't do very well after ablation. Now, the galectin, within the galectin, so that's a very good question, because in the galectin-1 study, we only looked at the moderate and the poorly differentiated. We didn't look at the well, because we felt like the well-differentiated HCCs are we already have good solutions for that. We're interested in the diseases that don't have a good solution. And so it was mostly moderate differentiated and poorly differentiated HCCs. And and I mentioned before, this data set is also very difficult to get because in the standard of care, and I don't know if that's something, I don't know what your tumor board is like here, but for hepatocellular carcinoma, the standard of care is to do imaging only. So you even get these biopsy samples is very difficult. And it's the first question I get when I go to radiology. When I present this at a radiology conference, is even though I think it's great, but like they always say, why did you biopsy in the first place? Why did you put this extra procedure for this patient? That's their first question usually. So there's a lot of inertia that we have to go against. But I think if you think about any other solid tumor, they have no question about biopsying to get surface marker, looking at PD-L1 expression, for example, right, or Ki-67, right? That's just standard of care. But for liver cancer, it is unfortunately still outside the standard of care.
Okay. And following up from that question, I was wondering if there is any precedent in your field, in interventional radiology, of the administration of targeted differentiation therapies, or if that is like a very novel topic or subject.
By differentiation therapies, you mean turning something that's poorly differentiated to well differentiated?
Exactly.
Yeah, so that theory, it's not a theory, I mean, I believe in it, but that, yeah, so that's, and of course, yeah, of course you want that because you would improve your chances of interactions with T-cell, right, with your T-cell based immune response. That is something that our lab studies, right, we use IFN gamma to turn something that's a poor differentiated to a well differentiated. But in in the radiology field, this is pretty new. Like most radiology departments don't have a wet lab or interest in immunotherapy. So I would say that's it's not very common. But I think I think that's a great pathway to improve the response of current like checkpoint inhibitor immunotherapy.
Okay. Thank you very much, Doctor.
More question? Allá, mira, por favor.
Dr. Chang, thank you for your nice presentation. I wonder, considering that temperature drops when moving radially from the center in thermal ablation, have you considered to increase the area to reach tumor margins?
Yeah, that's usually that's the first question people have is why don't you just make a bigger ablation zone? The answer to that is what is a little bit underappreciated is how vascular the liver is. The liver, your whole is however many liters per minute of blood is going through the liver. And so that actually limits the size of your ablation zone. 10, 15 years ago, they used, right now we use microwave ablation, but back then, a few decades ago, they used radiofrequency ablation, which they would use a small electrical current. They would treat the tumor as a resistive element and run a current through there and then passively heat the tumor. And the ablation size would only get to maybe 2 centimeters because at the peripheries, you don't have enough energy generated, but you have a big heat sink from the liver, and so you're kind of limited by that. And so that's kind of the issue here, is that with thermal ablation, unless you're using multiple probes, special techniques, it can be difficult to treat something over 3 centimeters. And so that's, and certainly, yeah, if you have a 2 centimeter tumor or 1 centimeter tumor, that you won't have any issue with margins. But when you get these larger tumors, they're small enough to be still considered a curative, but large enough that you may be leaving some residual disease behind.
Thank you very much.
Thank you very much for the next talk. I just wondering about abscopal effect. Do you know the percentage of your patients have this phenomenon? It is possible to improve it with some kind of cytokines or other molecules? And the other is, what about the vaccines combination with the radiology?
That's a very good question. I think our field is very interested in the abscopal effect. When we talk to other specialties, they don't believe in it, and so you can't both be right. So it's very rare. I would say the cases I see, they come from outside institutions. I personally, for my patients, I have not seen. Sometimes a tumor may be maybe a little bit smaller, but it could be because of measurement error. But I've never seen like a tumor just like disappear. I've seen tumors get downstaged to surgical resection. But it's so rare that it's not something you can really bank on. Now the question is, is there something we can do to maybe improve the chances? Maybe like 0.1% to 1%, right? That's a 10 times better improvement in the response rate. And I would say, it's not off the table. I think we just have to study it more. There's a lot of studies of evaluating abscopal effect in mice studies, not with liver cancer, but with like breast cancer, colorectal cancer. I think more studies need to be done, potentially focused on, how can we use our expertise in energy delivery to improve antigen presentation. So that's a very, it has to be a very kind of focused study. I think using cytokines to potentially improve the viability of your T cells or dendritic cells. I think those are all all different pathways that could improve your chances of getting abscopal effect. But at this point, I think it's mostly a theoretical thing that people are interested in. I would not tell a patient that let's hope for an abscopal effect. I think that would be doing them a disservice, actually. But I think as an academic question, I think it's something that's very interesting. And your second question was, repeat that.
About vaccines.
The vaccines. Yeah, so the vaccines is also a very hot topic. In our institution, we have a lot of trials on dendritic cell vaccines, improving antigen presentation with dendritic cells, improving the connection with like the T cells. So that's something that would potentially benefit actually from local delivery. We were part of a trial a few years ago for lung cancer. So at least I know that it's potentially a safe procedure, and you might be able to get higher titers with the vaccine through local delivery. So again, we're just scratching the surface here. Like everything I present here, I feel like is pretty new, and it takes a lot of buy-in and collaboration with the oncologist and the interventional radiologist. So stay tuned.
Thank you.
Yeah, and that question is very interesting. Dr. Chang, because now with the supercharging K that are together with the ablation, so the NK also can increase the interferon gamma secretion, the TNF, so maybe that will be the answer for that, that you decrease the tumor with the ablation, but then you increase the immune system of the patient, and then together can eliminate the tumor, even without surgery, right? So this is our guess.
That's right, and I think this idea of like sublethal hyperthermia should not be underestimated, because when you heat tissue, you also increase the vascularity, right? Like just like when you have a small fever, you have your blood vessels open up. You can push, different kinds of cell-based immunotherapy deeper. So it's not just changing the surface marker, but just like the physical architecture of the tumor itself will change when you heat the tumor. So yeah, it's definitely a very interesting topic that we're pursuing.
Yes, and if you remember the person that can hear my job with supercharging K, now we are treating patients with supercharging K in Mexico. So maybe in the future we can use the supercharging K in patient together with the ablation. So we are a little far away, but we are in the right way to do that.
Yeah, and I think, by the way, like this ablation is standard of care. Like that is standard of care, and I think to combine immunotherapy, like NK cell immunotherapy or CAR T therapy, it has to be on the backbone of standard of care. And so that's why what we work right now is under the assumption that you would pair the NK cells with standard of care. So you're not, because again, the ablation works pretty well for a lot of patients, right? You don't want to take that away and put, hey, try NK cells now. You want to make sure you do that. And for the subpopulation of patients that have recurrences on the margin, you can clean it up with like the NK cells.
Yes, and this is a different question, but how much the ablation is cost? It's a very important question for us.
It is, yeah. So depends on, I don't know how the insurance works in Mexico.
I know, yeah.
But in America, yeah, it depends on your insurance and whether you're cash paying or your insurance is paying for it. The hospital gets very little compared to like a Y90. Cash paying, it might be $20,000, $25,000 US. If you're going through insurance, maybe probably like $5,000, which does not really cover actually.
But it's around 20,000.
Cash, if you're doing cash, yeah.
Okay.
If you're doing insurance, I don't know if you have the same thing, but like the hospital collects a fee and then the physician collects a fee, right? And so the physician fee is like very low. Probably like $2,000, and then the other $3,000 go to the hospital. So it's not a lot. I don't know.
Yeah.
Compared to other therapies that we offer, like the Y90 or the catheter directed, which can be like over 100,000. So.
Okay. Thank you. So do you have any more questions? No? Yeah, sure.
Thank you for this very interesting talk. As you can see, we are all very worried about these patients that even with the thermal ablation, they don't respond. Well, initially they respond, but they relapse. So perhaps could you use liquid biopsy technologies to evaluate these patients to detect, for example, circulating cells or even mutations to see which ones are going to relapse faster or relapse in the end?
That's a great question. And I would say it depends on the treatment that you're administering. So with thermal ablation, I can tell the response very quickly. I know my margins relative to the tumor within a couple hours after the ablation. I can just get an MRI and look at the T1 weighted sequences. We have a very close surveillance program. So I image them 1 month and then every 3 months after that. So I can always see if there's going to be a recurrence on the follow-up. And if there is a recurrence, because this is a minimally invasive procedure, I can just treat them again, right? And so, and people do very well with that. Now, the harder part is, I think, with these systemic therapies is like, I don't know if it's actually working. Like, you don't really know. And on imaging, sometimes there is an inflammatory response, and you're like, is that tumor or is that inflammation? And in those cases, yes, you definitely need to have maybe a blood-based biomarker. With liver cancer, with HCC, at least we use AFP, but not all HCC patients are AFP producers. And so it becomes very tricky. You know, we have collaborators that look at extracellular vesicles, for example. That's a potential biomarker, but it's still kind of very research-based. And we found a promising signal with extracellular vesicles. These other liquid biopsy, that I think there's circulating tumor markers, for example. Those are all possibilities as well. But potentially, you know, you're looking at systemic, you know, you're drawing venous blood and saying, oh, I hope it tells me a signal of what's happening locally. What I kind of mentioned here is that you could actually put a catheter up to the draining vein of that tumor and get a very sensitive kind of signal, right? If you have no tumor markers coming from the draining vein, then you probably don't have a lot of viable tumor there. Whereas if you have a lot of viable tumor coming out of that vein, then you probably have a treatment there. So that is an interesting possibility. And we do this for adrenal vein sampling, for example. And so that's the precedence that we would follow.
Thank you.
Hello, doctor. Thank you so much for your talk. I have two questions. You can consider NKT cell therapy in the tumor, and most of the patients have immunodeficiency. Sorry, but you can priming the immune system. How you can face this challenge?
Yeah, so your first question is specifically with NKT cells?
Yes.
Or is it NK T
yes, sorry.
NKT cells. Yeah, the NKT cell population is a very interesting kind of way to do it. I think I have a colleague who does NKT cell kind of work. I think part of it is collecting the NKT cells in the beginning. The population is like so low, and to begin with in humans. I mean, I think it varies from person to person, but that is a possibility. And you may be able to get the best of both worlds of the NK and the T cells. So that is an active area of research. And the second question was about immune priming for
immunodeficient
patients. Yeah, that's a really good question as well. So in general, like these patients with early stage cancers are generally not immunodeficient. They're usually pretty healthy, actually. Like ECOG 0, very good functionality. If they're immunocompromised, then it's possible that you may not need to do lymphodepletion before doing CAR T. So I think they potentially would respond. Now, if they're immunocompromised, then you are worried about that they're not actually going to be able to mount an adaptive immune response. But potentially, if you're doing allogeneic NK cells, you're just dropping these NK cells and hoping it just kills whatever it touches. That's still on the table, and so that's probably how I would steer the conversation, if that came up with immunodeficient patients.
Thank you, doctor. Okay, could you please?
Thank you, Dr. Chang, for this great talk, and I hope that we continue to have a collaboration with you and Sara. Thank you very much.
Absolutely.
Thank you very much.
Much.
Muchas gracias a todos.